All right, let's dive right in. Today, we're talking about an organism that can be a real headache in the clinical lab, Nocardia brasiliensis. You know, it's one of those bugs that's a bit of a chameleon. It's a bacterium, but it loves to act like a fungus. This makes it a master of disguise and a serious challenge for even the most seasoned microbiologists. So in this explainer, we're going to give you the toolkit you need to unmask this tricky pathogen, all the way from getting a solid ID to navigating the complexities of treatment.
And just a quick note up front, for full transparency, all the information we're covering today was compiled using a Gemini deep search. For any of you who really want to get into the weeds and check out the primary literature, the complete list of sources is right there for you in the accompanying notebook document.
So here's our roadmap. First, we'll get properly introduced to Nocardia brasiliensis and figure out its place in the microbial family tree. Then, we're heading into the lab to look at the nitty-gritty of how we actually pin down a diagnosis. After that, we'll connect what we see on the bench to what's happening at the bedside, the diseases it causes, and of course, the best ways to treat them. And to wrap it all up, we'll tackle those big picture challenges of susceptibility testing and lab safety.
Okay, let's start with the fundamentals. You know, before you can really understand a pathogen, you have to know who it is and where it comes from. So, who exactly is Nocardia brasiliensis?
So at its heart, Nocardia brasiliensis is a gram-positive aerobic actinomycete. The key thing to remember is that it's a bacterium that grows in these long, branching filaments, kind of like a fungus. It's an environmental bug living happily out in the soil, which is the big clue for how people get infected. The classic story is some kind of traumatic inoculation. Think a thorn prick or a scrape while gardening, which introduces the bacteria into the skin and kicks off the infection it's most famous for, Actinomycetoma.
Now let's quickly look at its family tree. Nocardia brasiliensis belongs to the order Mycobacterialis. Yep, that means it's a distant cousin to the mycobacteria, like tuberculosis. But here's the crucial distinction. It's in its very own family, the Nocardiaceae, and that little taxonomic detail is actually the secret to understanding some of its unique lab characteristics, especially its tricky staining properties.
All right, let's see how this all plays out in the real world of the lab. You know, identifying Nocardia brasiliensis used to be this really long, drawn-out process. But these days, thanks to some incredible technology, we can get a definitive ID way faster.
So your very first clue is almost always going to come from the gram stain. What you're looking for are these really delicate gram-positive filaments. The classic features to watch for are the branching, which can sometimes happen at these sharp 90-degree angles, and this characteristic beaded appearance, where the stain looks kind of uneven along the length of the filament. Seeing this in a direct clinical sample, like pus, is a huge tip-off that you might be dealing with Nocardia.
And this brings us to a super important concept, partial acid fastness. You see, unlike Mycobacterium species, which have these really long-chain mycolic acids that grab onto the acid-fast stain for dear life, Nocardia has intermediate length chains. What does that mean for us? It means you have to use a weaker decolorizer, like in a modified Quignon or Zeal-Nielsen stain. When you do it right, you'll see it. Some parts of the filaments will hold onto that red carbofuchsin stain, while other parts will decolorize and pick up the blue counterstain.
Now, on the culture bench, patience isn't just a virtue, it's an absolute requirement. Nocardia brasiliensis is a slow grower, and I mean slow. You have to be prepared to hold those plates for up to 4 weeks. This is so critical. A 4-week delay for an ID can mean a patient is on the wrong therapy for a whole month. That's why that initial gram stain is so vital and why it's so important for clinicians to give the lab a heads up if they suspect Nocardia. But when it finally grows, the colonies are pretty distinct. They're often chalky, wrinkled, and have these fuzzy aerial hyphae. And, you know, a lot of old school microbiologists swear you can smell it, that really distinctive damp potting soil odor.
Okay, so back in the day, we relied on tables like this one to piece the puzzle together. By combining some simple biochemical tests with known intrinsic resistance patterns, we could differentiate the species. For example, say you have an isolate that hydrolyzes tyrosine. Well, that narrows it down, but it could still be Brasiliensis or Pseudobrasiliensis. But then you look at susceptibility. Nocardia brasiliensis is typically resistant to imipenem and ciprofloxacin, while Pseudobrasiliensis is susceptible. Boom! That's a critical distinction that directly impacts treatment choices.
But today, thankfully, we've got much faster and more accurate tools. The modern workflow usually starts with MALDI-TOF mass spectrometry. This has been a total game changer, giving us a reliable species-level ID in just a few minutes right off the culture plate. If MALDI-TOF gives an ambiguous result, or if we need absolute confirmation, we move to 16S rRNA gene sequencing. That's still the gold standard.
And for those rare cases where you need to do some high-level epidemiology, maybe for an outbreak investigation, you can use multi-locus sequence analysis. Okay, let's switch gears and move from the bench to the bedside. We've figured out what it is in the lab, but what does an infection with Nocardia brasiliensis actually look like in a patient?
The most common way it shows up, especially in people with a healthy immune system, is disease of the skin. The absolute classic presentation is actinomycetoma, which has this unmistakable triad of symptoms: a firm, swollen lesion, multiple sinus tracts that drain pus, and these tiny, visible clumps of the organism we call sulfur granules. It can also cause something called a sporotrichoid syndrome, with nodules tracking up the lymphatic channels, which can really mimic a fungal infection. Or sometimes it just looks like a more routine skin infection like cellulitis or an abscess.
But in an immunocompromised patient, the whole story changes. It becomes much, much more dangerous. Here we're worried about severe lung infections and disease that spreads throughout the body. The pulmonary infection itself can be pretty nonspecific, but the real terror is when it disseminates through the bloodstream. Nocardia has this frightening tendency to go to the central nervous system, and brain abscesses are a frequent and absolutely devastating complication.
And that leads us to what is, without a doubt, a critical, non-negotiable clinical rule. You must get brain imaging for any patient diagnosed with pulmonary or disseminated nocardiosis, full stop. It doesn't matter if they feel perfectly fine with zero neurological symptoms. Finding a hidden or occult brain abscess happens all the time, and discovering it completely changes the treatment plan. It means you need different drugs that can get into the brain, and you're looking at a much, much longer course of therapy.
So that brings us to treatment. How do we actually manage these really complex infections? Let's jump into Section 4 and compare some of the different guidelines out there. Okay, so here we can see a comparison between different approaches. For the straightforward, mild skin cases, pretty much everyone agrees. Oral monotherapy, usually with trimethoprim-sulfamethoxazole, is the way to go. For severe infections, again, there's consensus on starting with aggressive IV combination therapy. But this is where it gets interesting. The specific drug choices can differ. For instance, notice how the Dutch protocol suggests an imipenem-based regimen for severe disease. Well, as we already know, Nocardia brasiliensis is intrinsically resistant to imipenem. This is a perfect illustration of why getting that species-level identification is so unbelievably important for guiding therapy.
Now, when we're treating kids, the same principles apply, but the dosing gets a bit trickier. Everything is based on the child's weight, so it requires very careful calculation. Trimethoprim-sulfamethoxazole is still the workhorse, especially for mild to moderate disease. But as you can see, for the really severe infections, or especially if the central nervous system is involved, you've got to hit it hard and ramp up that dose significantly to give them the best chance at a full recovery.
All right, let's head into our final section and tackle some of the biggest practical hurdles we face in the lab and clinic: susceptibility testing, prevention, and of course, safety.
And this brings us to a really major fork in the road. I want to pose this question directly, especially to our colleagues in Europe and other parts of the world. What on earth do you do if your lab follows EU-CAS standards for susceptibility testing?
Here's the problem in a nutshell. The Clinical and Laboratory Standards Institute, or CLSI, which is used widely in North America, has a document with clear, validated, species-specific breakpoints for Nocardia. You get a minimum inhibitory concentration, or MIC, you look it up, and you get a clear answer: susceptible, intermediate, or resistant. Simple. But for labs that follow the European Committee on Antimicrobial Susceptibility Testing, EUCAST, those definitive clinical breakpoints for Nocardia just don't exist yet, and that creates a huge problem, making it incredibly difficult to give clinicians the clear, actionable guidance they need. So what could you actually do? Well, there are a few pragmatic workarounds. The most common solution is for the lab to just go ahead and use the validated CLSI breakpoints and simply add a comment to the report explaining what they've done. Another option is to use what are called epidemiological cutoff values, or ECOFFs, which can tell you if an isolate is wild type or not, but that doesn't predict clinical success. And the last resort, which really isn't ideal, is to just report the raw MIC value and leave it up to the infectious disease specialist to interpret.
And just to wrap up with a couple of key safety points. The good news for patient care is that Nocardia is not transmitted from person to person, so good old standard precautions are perfectly sufficient. In the lab, however, it's a different story. It's classified as a biosafety level 2 pathogen, which means any procedure that could create an aerosol, and that includes something as simple as vortexing a tube, must be performed inside a Class 2 biological safety cabinet to protect the technologist.
You know, this whole conversation about CLSI versus EUCast really leads to a much bigger, more thought-provoking question that goes way beyond just Nocardia. In our increasingly connected world, how can we do a better job of harmonizing our global testing standards, especially for these rare but really important pathogens? How do we ensure that every patient, no matter where they are in the world, benefits from clear, consistent, evidence-based guidance from the lab?
And that's our deep dive on Nocardia brasiliensis. We really hope you found this helpful. If you did, please go ahead and subscribe to the channel. We'd also love to hear from you. Share your own experiences with this organism or any feedback you have in the comment section below. Thanks so much for watching.